Hey guys, thanks for joining us for EMS Challenge. We'll get started here in just a second. We kind of switched it up. Dr. Saeed's going to talk first, and then I'll kind of finish this up. For those of you not aware, EMS Challenge, we stream this live twice a month. We're supported by the Fire College. You can get EMS, nursing, or physician CME, Con Ed, whatever you need. There's no charge for this. We normally do a skills lab, but with the all the stuff going on at the conference, we're not doing that today. But our next class will be in Springville, Alabama on December 11th, and we'll do lectures in a skill lab there. We try to hold cadaver labs about 3 times a year. Our last one was August. We can't do one this December because they're doing construction at the cadaver lab at the med school, but I'll have another one in the spring. And these are free to EMS providers. There's no charge for it. You come in, we do chest decompression, do IOs. The first couple of groups can do chest tubes and surgical airways. After that, it kind of runs out. So. All right. And we'll be streaming to some folks today. If you have a question, just raise your hand. I'll come to you with the mic so that way the folks in Zoom land can hear us too, okay? You ready, Chief? All right. It's all you.
Can anybody hear me? All right, y'all. So my name's Saeed. I'm a second-year emergency medicine resident at UAB. I used to do EMS prior to going into medical school and becoming a doctor. I did that for about 10 years, and then I did critical care transport for a couple years before I went to medical school. So I like to show perspective of what our pre-hospital providers see on scene instead of us docs with the knowledge that we have when y'all get there. So I'll kind of give y'all a little bit of an idea of what we should be doing in the field, and then what happens when the patient comes to us, a little bit of what we're doing when the patient's there, all right? I chose the topics on congestive heart failure and AFib for management of EMS providers because it's very complicated on how to do it, but also it's very basic physical exam and understanding what we need to do on scene and what we can do during transport and then getting to the hospital, all right? So I have no disclosures. I'm not getting paid by anybody. I'm here on my free will and just for the vibes, all right? So objectives of my presentation is really to understand the pathophysiology of what causes congestive heart failure, what type of heart failures there are, and what causes AFib, and how we could treat it, right? Diagnostics, how EMS provider can recognize what's going on, how they could differentiate what's going on, and then interventions, what we carry on our rig, what we could do to kind of help the patient improve their symptoms and what to look out for once we do help them, right? And then for decision making, right? Like, where do I need to transport this patient? What do I need to do during care of this patient? All right. And what do I need to keep an eye out for? So pathophysiology. Now, my lecture is going to be talking about 2 different topics. So try to keep up, if y'all get confused, please let me know. I'm going to go through CHF and AFib together. All right. So first off, let's talk about the pathophysiology of congestive heart failure. All right. There are 2 types of heart failure that you'll get. All right. There'll be systolic heart failure and then diastolic heart failure, right? One is when you're pumping, one is when your blood is being filled, right? Then you have right-sided heart failure and left-sided heart failure, okay? Now, the difference in systolic heart failure, what's happening is your muscles are weak of your heart, right? They're basically getting dilated and they're not pumping out enough blood, causing you to have a reduced ejection fraction. So systolic heart failure, a lot of times it's called HFrEF in the medical, you probably heard it. Heart failure with reduced ejection fraction. And just for y'all's knowledge, the ejection fraction that puts us at reduced heart failure is less than 40%. So basically your heart's pumping less than 40% out into the body, all right? So the ejection fraction decreases, and then that causes your cardiac output to decrease, all right? And so this is leading to heart failure, causing your everything to get backed up in your system. Then in diastolic heart failure, what's happening is you have a lot of afterload. Afterload meaning you have a lot of pressure that your ventricle is trying to overcome to push the blood out, all right? As with anything, as you push more out, your heart starts to get stronger. The ventricle gets stronger, you build more muscle on it, and your chamber in the ventricle gets smaller. So your ejection fraction stays the same, right? You're still pumping whatever's in the ventricle out, but you're not filling as much. So that's what's causing your decreasing your cardiac output. All right. So, the common causes that could cause systolic heart failure are heart attacks, because what heart attack will do is cause remodeling of your ventricle, causing some fibrosis to happen, so that your ventricles become stiff. All right. Another reason is that they're just dilated cardiomyopathy. They're already just very big, and it's ventricles, so you're not squeezing as much. And then very uncommon reason could be myocarditis. So this is basically your heart is being irritated, it's not pumping as it should. All right. For diastolic heart failure, basically the most common causes, especially in Alabama, is chronic hypertension. I can tell you how many times I've seen in our ER, almost all of my patients' systolic blood pressure was in 200, and they're just talking to me. They're not taking any of their blood pressure meds. That's going to lead you to systolic heart failure. All right. And then another biggest reason, as we get older, we get calcifications on our valves. So you have aortic stenosis. So basically, your aorta is getting calcified and it's putting more afterload pressure, so you're not pushing out as much blood anymore, leading to diastolic heart failure. Anybody know how to calculate your blood pressure? The formula for it? I know this is very like first basic stuff, but it's the pathophysiology of heart failure really makes you understand how to do it. So your blood pressure equals your cardiac output times your systemic vascular resistance, right? So our cardiac output is dropping. We're most likely hypotensive. Then our body needs to basically compensate for this. The way our body compensates is puts in systemic vascular resistance. So our arteries and veins in our system get very constricted. Your sympathetic system kicks in, right? This is where norepinephrine and epinephrine kicks in your system. Due to baroreceptors in your vessel, they're noticing that you're not getting enough blood, so we need to get more blood to the system. All right. This causes an increase in your afterload, and you increase it. Your body's trying to help the heart by becoming tachycardic, but they're increasing the system resistance, causing more afterload. So more pressure is being used, which entails going to worsen your diastolic heart failure, basically making it worse. All right. At the same time, your RAS system is also kicking in. Your renin, angiotensin, aldosterone system, right? Renin and angiotensin is going to cause systemic vascular resistance. All right. This can cause more afterload. It's going to increase your preload. As you increase your preload, you're going to dilate your ventricles more. As you dilate your ventricles more, that's going to worsen your systolic heart failure. And then with aldosterone, what it's going to do is it's going to retain sodium. As you retain sodium, it's going to retain water, and that's where your pitting edema starts happening, right? So basically, your body thinks that it's trying to help you, but it's actually worsening your heart failure. So this is a picture of basically what a normal heart looks like. So on a healthy heart, you'll see everything's pumping well. You see the muscle is good. And then as you get systolic heart failure, so this would be systolic heart failure because you see your left ventricle. I wonder if it has a pointer on here. Oh. On the left ventricle, you see it's very dilated. So that's causing your muscles of your heart to become weak, and it's not going to push out enough blood. All right. So I know that was a lot, but that was just heart failure's pathophys. I really believe if you know the pathophys of what is going on with the heart, you can understand what we're going to do to treat it. Okay. Now let's talk about AFib a little bit. All right. So in AFib, basically what's going on is it's called supraventricular tachycardia. So basically, the problem is above the ventricles in your atrium, right? It's uncoordinated, chaotic electrical activity, causing basically your atriums are just going away, just no coordination at all. You're not getting any good contractions going on. You're not able to fill your ventricles at all. All right. So the causes for AFib, there are two types of causes. There's cardiac causes, and then there's non-cardiac causes, right? Cardiac causes being valvular AFib, valve problems. So the valve between your left atrium and your left ventricle is the mitral valve. So now you can have mitral valve stenosis. Basically, your mitral valve is so tight that it's not pushing enough blood in, causing more pressure to form. And just like diastolic heart failure, your left atrium starts to get bigger. As your left atrium gets bigger, the cells around your pulmonic veins that are coming into the left atrium, they start acting up, and then your electrical conduction system's off. Now you have irregular activity causing AFib. Another reason, just like I just talked about, is heart failure. Heart failure causes everything to back up, gets dilated, and it could cause AFib. So that's why for EMS providers, right, we need to know what is the underlying cause, right? Am I treating AFib or am I treating heart failure? Because both of them could show up looking the same way. So that's why you got to be very cognizant of when you're treating these patients of, all right, I treated AFib. Now the patient was in heart failure with their ejection fraction was 10%. Now I just basically put them back in sinus rhythm, but they're not pumping at all. They're gonna crash, right? So I need to be ready with my push dose epinephrine drips. So I need to be thinking about what will happen if I treat this patient, which is fine. You just need to know what to do next. All right. Every time you make a decision for an intervention or a treatment, always have the thought process of what's next or what could go wrong. Otherwise, you're kind of doing something and then you're kind of out of luck and you don't know what to do and your patient's decompensating. All right. The non-cardiac causes. Oh yeah, I'm sorry. Cardiac causes also, as always, heart attack. Heart attack will cause your heart to become stunned. That part of the heart isn't working anymore. Electrical activity is not going to happen, cause irregular electrical activity. Non-cardiac causes will be COPD, PE. Oh man, I'm sorry. COPD, PE, anything that causes hypoxia. Because with hypoxia, the cells around your atrium, where the pulmonary veins brings the blood through, they get really excited when they're not getting any oxygen at all. Causing hypoxia will cause leading to ectopy. Ectopy is what basically causes AFib. All right. Other things that will cause ectopy to increase will be sepsis. So I always try to treat the underlying causes for AFib, right? Sepsis could cause this. Thyroid toxicosis, basically hyperthyroidism, right? It's not much we could do for hyperthyroidism in the field, but it's something you should ask your patient or a family member patient, do they have hyperthyroidism, right? Or are they taking the meds? Electrolyte disturbances, so hypokalemia, hypomagnesia could cause this as well. So always look at your rhythm, try to see what we could do for them on that type. Do I need to give this patient calcium? Do I need to give this patient bicarb, right? What can I do for this patient right now when they're with me, okay? Now, we're about to go into a holiday season, right? And holiday season, this is a rare complication, but you might see this a lot more. A lot of people binge drink, all right? Binge drinking could lead to AFib. It's called holiday heart syndrome. Holiday heart syndrome happens. Just know that that's the reason of their AFib. And if they're unstable, we'll talk about how to treat that. All right. Another reason, I mean, we see this a lot in Birmingham as well, is drugs. So cocaine, leading to AFib, irregular heartbeats. All right. The electrical conduction system, I feel like we should just kind of go through it a little bit. I like this picture a lot because it's also showing you guys where on your EKG each node is acting up. So your electrical conduction system goes through your SA node, through your AV node, then your bundle of His going down to your ventricles to the Purkinje fibers, right? As your SA node and the AV node are firing, you see your P wave is contracting. So your atria is contracting, right? As you go down your bundle of His, your atria should be repolarizing and your ventricles are starting to contract, all right? I think if you picture this in your head, you'll know where, when you look at your EKG, you know where the electrical activity abnormality is happening, right? Knowing just the basic underlying method, you'll be like, all right, this is in the atria, this is in the ventricle, this is the left bundle branch block. Why is this a left bundle branch block? I think this is because their left-sided bundle isn't working, all right? I put these in, these just to let you know about left side or right side. I think these are way too detailed, so I'm just going to slide through these real quick. Once we know the pathophys now, we need to see what a patient presentation would be like. What would this patient show up in our on the field, on the scene would be like, all right? So the most important thing for any provider, any medical provider, is your assessment, right? That is something we need to be really good at. I think it's a moral imperative that we be good at our assessment and physical exam, right? We need to find out what's going on, get the story, because you're never gonna get the full story. All you'll get is when you get called sick person complaining shortness of breath, sick person complaining chest pain, and you get on scene and it's chaotic. You don't know what to do. So you need to be able to have a focused history, figure out the pertinent questions you need to ask. I don't need to know what they did 3 years ago, but I do need to know, when did it start? What is the most recent complications? Did you have recent surgeries? What medications are you on? Did you miss medications? Are you on dialysis? Did you miss any dialysis appointments, right? I'm not here to judge you. Are you taking any drugs? That's fine. Like, I don't care if you do. I just need to know so that I could treat you appropriately. All right? For vital signs, right? Don't just focus on your monitor. Look at the patient. Touch the patient, right? Your monitor can be lying to you. So you need to know, like, what is sick and not sick, right? If I'm looking at the patient, like, man, this patient, I know my monitor is telling me one thing, but this patient looks like they're going to decompensate fast. I need to start moving. I need to start doing things, right? You need to know, are they tachypnic? Are they breathing really fast? Are they dyspneic? Are they having difficulty breathing, right? What is their SpO2? Are they hypoxic, right? Are the extremities cold? Why are the extremities cold? These are the questions that I would start asking. Like, why are these extremities cold? Why am I not getting any kind of waveform on my SpO2, right? Blood pressure. Is this patient hypotensive? Is this patient hypertensive? Is this patient normotensive? Because that all puts in the complete picture of what I need to do next. Tachycardia, bradycardia, normal cardia, right? If they're normal, are they on a beta blocker, right? Because this patient does not look right to me. This patient looks sick, but their heart rate's fine. What's going on? Like, what am I missing, right? Bradycardia, is this electrolyte disturbance? Is this patient got a pacer? Does this patient have bradycardia? That's where they live at, right? This is another thing you want to ask them, like, what is your normal heart rate? Do you live at this place? If they're talking to me fine, their heart rate's 40, but there's nothing, they're not complaining or anything, I'm not doing anything. I'm like, hey, let's keep it moving. I'm not gonna pace you. I'm not gonna give you an atropine or nothing. Asymptomatic bradycardia is fine, right? It scares you. It scares me more than the patient actually would. But you're looking at them like, they're talking to me, so that's a good sign. Let's keep it moving, right? End-tidal CO2. I think this is very important, especially, I don't know if y'all saw the lecture yesterday about ketamine use, right? You give somebody ketamine and then put them on oxygen, yeah, their SpO2 looks great, but they're not breathing. We're just giving them passive O2, but we took away their respiratory drive. We don't have end-tidal CO2 on. We have no idea if this patient is breathing or not. And we're missing important steps in our management of our patient, right? Don't get too focused on your monitor and your EHR and forget to look at the patient. Physical exam. I cannot stress the importance of touching your patients, right? Feel the pulse. Is it strong? Is it thready? Is it weak? Is it regular or irregular? Right there, you feel the pulse, irregular pulse. You kind of have an idea of, like, I might have AFib going on, right? Weak pulse, I might have some sort of shock component going on. Why is this pulse weak? Do they have a pulse? That's another thing, right? You show up to an ultimate status patient, you're over here talking to everybody. Has anybody checked for a pulse on this patient? Do they have a pulse? You'd be surprised how we overlook stuff like that. Okay? Cardiac exam, right? Am I hearing any kind of extra noise? Now, I would say in the field, I'll be very impressed if you came to me in the ER and said, yeah, doc, I heard an S3 gallop. I was like, how did you hear an S3 gallop in all that noise with the truck running? And does anybody know what an S3 gallop is? All right. So there you go. S3 gallop is basically when you have heart failure, is your heart normally goes lub dub, and then after the dub, you'll hear another sound. Sound, all right? And that's your S3 gallop. I can tell you, I'm in the ER and I've barely heard it from time to time. You come to me and say, I heard this murmur. Unless this murmur is super loud, I'm going to be very impressed with you because I'm like, I don't hear nothing. All right. But listen to the heart. Make sure you are hearing at least something, right? Lung sounds. Am I hearing wheezing? Am I hearing crackles, rails? What am I hearing? Well, what's going on in the heart? Or is there fluid in there? Right? And then touch your patient. Is my patient's extremities cold? Is my patient have pitting edema going on? Does my patient's stomach, is it soft? Is it tender to touch? Does it feel like they have a lot of ascites built up in there? All this will build a picture towards what I need to do next. And all of this could be done in 5 minutes or less, right? It doesn't take long to do a full physical exam. Do a good neuro exam as well, right? Like, does this patient know where they're at? Can they move everything, right? Is there some sort of sensation differences? Are they having some sort of radiculopathy or something like that? So signs and symptoms of heart failure, right? You'll get dyspnea, you'll get orthopnea, you'll get paroxysmal nocturnal dyspnea, all right? Nausea, vomiting, and weight gain. With left heart failure, what happens is your fluid starts backing up into your lungs, right? You start getting congested, the fluid goes into your alveoli, and now you're getting pulmonary edema. Pulmonary edema, when you lay flat, the fluid kind of distributes and they can't breathe anymore, right? So this way, like, all right, what's going on? Biggest thing to be concerned about with pulmonary edema is that heart failure is not the only cause of pulmonary edema. There are many other things that can cause pulmonary edema, so don't just kind of lock down that this has to be heart failure, right? It could be trauma, it could be pneumonia, it could be other interventions, that infection going on to say that they have pulmonary edema. So if you hear crackles and rails, just know that this is not necessarily heart failure yet. You got to put the full picture together. In right-sided heart failure, what you'll see is JVD. So your right side, your ventricle, everything's backing up, going into your systemic circulation. So your venous jugular vein will be distended. You'll get hepatic congestion. Basically, so what's going on is your stomach is getting fuller. You'll see ascites. You'll see pitting edema. This is where you see pitting edema going on. And I think that's a pretty good example of pitting edema. You put your finger on the extremity, you move it, and your fingerprint is still there. That's really good, big example of it. Now, there's no scoring system for pitting edema really that's regulated. Just tell us, like, he has pitting edema going up to the knees, pitting edema going up to the ankles. Just be descriptive. You don't have to say 2+, 3+. I don't know what that means. Just tell me, is it at an ankle or is it at the knees? All right. Weight gain too. Ask them, have they gained any weight that they might not know of? That means they're holding on to fluid. This picture kind of summarizes left-sided heart failure and right-sided heart failure. Right-sided heart failure is known as cor pulmonale. Most common cause for right-sided heart failure is left-sided heart failure, right? What's going on with left-sided heart failure is you're putting more fluid into the lungs, causing pulmonary congestion, and pulmonary congestion is causing you to have diastolic heart failure on the right side because you can't push through. Now you got cor pulmonale, all right? So in this picture, you can see the gentleman, he has paroxysmal nocturnal dyspnea. He's going to be restless, right? Now, confusion. Why would that patient be confused, all right? So like we talked earlier, your cardiac output in heart failure goes down. As your cardiac output goes down, you're not perfusing anymore, right? So when you touch your patients, you notice they have cold extremities. It's because they're going into shock. Their blood is just being used in the vital organs, but they're not getting as much blood to the brain because you don't have enough blood going out. That's going to lead to altered right? So if you see an altered patient, don't just assume that it's just possibly dementia, possibly opioids or alcohol or something on board. look at a medical reason for it, right? So these patients could show up altered. They'll be tachycardic, just like I talked. They'll be tachycardic because their sympathetic nervous system is acting up because your body's trying to help your heart out. Okay. Always ask heart failure patients, how far can you walk before you get short of breath? And has that changed? That lets you know a lot. Like, is this a acute decompensated heart failure patient going on? Ask them, what is their baseline oxygen? Are they always on oxygen? If they are, what did they stay at? Are they requiring more? Because that's letting me know that this is acute on chronic decompensated heart failure right now. You will see Blunt's sputum is because they're coughing a lot because of the fluid on their lungs. All right. On the right side is what you'll see: the pitting edema, the lady, the cor pulmonale. You'll see pitting edema. You'll see JVD. You'll see ascites. You'll see hepatic congestion. You might see hepatomegaly and splenomegaly as well. All right. Now, this is just for our hospital providers. I kind of want to show you like what we do when you get to the hospital. One of the biggest things we'll do is get a chest x-ray right away. And in the chest x-ray, you want to know, what am I looking at, right? The approach that I was taught in medical school and in residency is when you look at a chest x-ray, the mnemonic that was told to me was A, B, C, D, E, right? First thing I want to do is look at the airway. So is my trachea there? Is it moved anywhere? Is it patent? I'm looking at the carina. I'm looking at lung markings on both sides. Are they going all the way out to the ribs, right? If they're not going all the way out, why are they not going all the way out? Then I'm looking at B being bones. I'm looking at all the bones. Are my clavicles, are they lined up? Is there any fractures anywhere that I'm missing, right? Is it all the bones in the space where they need to be? Then I'll go to C. C is my circulation. Then I look at the heart. All right, is the heart enlarged? Can I see my aortic knob and my AP window, right? Is the heart where it's supposed to be? That's you'd be surprised. Is the heart where it's supposed to be? Is there fluid around the heart? Is there air around the heart? And then D, I'm looking at the diaphragm. So this is where it's important. The diaphragm and the costovertebral angles. This is where it's important for heart failure. I'm looking at, are my diaphragms equal? Are they elevated? Is one above higher than the other? Or are they lower than they need to be? And then I'm looking at my costovertebral angles, looking at, can I see the sharp angles? If I can see the sharp angles, that's letting me know less likely there's any fluid buildup right there, because the fluid is going to build up most likely start right there in the costovertebral angles. All right. Now, when pulmonary edema happens, you'll see that the fluid will go into the alveoli, causing pleural effusion to happen. And then that's the chest x-ray you'll see. In this chest x-ray, okay, airway, I can see the airway. I see the bones are good. Now, I go to my C, I can barely see the heart. Heart's huge in this one, right? You have a big heart. I can't see my aortic knob. I can't see my window anymore. Then I go to my diaphragms. Can't really see the diaphragm. And then I see, looking for my costovertebral angles. They're not there. So it's leading me to think that they have some sort of pleural effusion, some sort of fluid buildup right there. Okay. In this situation, we'll talk about in treatment what we need to do for these patients as pre-hospital providers. Okay. Now let's talk about the clinical presentation of AFib. So most of the time, you'll hear patients say that my heart is racing, right? It feels like my heart is going to jump out of my chest. I have chest pain. I'm having a hard time breathing. I'm getting very tired. And all of this is happening because your atria is contracting so big, so much that it's not allowing enough blood to be pumped in and then pumped out of the heart, the systemic system. So your perfusion, you're malperfusing. All right. These patients will also complain of feeling lightheaded, syncope, dizzy. You want to be cognizant of the fact of why this is happening. Then AFib or RVR can happen, right? So your ventricles are trying to compensate for what the atria is not allowing you to happen. So your heart rate will go up to 150 beats per minute, right? Which is allowing less filling time of the blood. So you're getting less blood to the systemic perfusion. AFib or RVR, you want to know what is driving this patient to be in AFib or RVR. So one of the main causes for AFib or RVR could be, is this sepsis? Do I need to start this patient on fluids, right? Is this patient in hyperthyroid thyroid storm? Can't really do much for them, but let's get them to the hospital quick, right? Is this a heart attack going on, right? Let's look at our 12 lead EKG. Let's see what's going on, because I could at least try to get them to the right appropriate hospital. And then on your physical exam, say that your monitor is not working, feel for a pulse, Is it irregular? You have an idea where we are. How fast is it? You could count it, right? How fast is the pulse? And then you'll see signs of CHF combined with this. So make sure that we're also treating CHF symptoms if we have it in our initial assessment. All right. Now, as we work 24-hour shifts, 36-hour shifts, or whatever, you're tired, right? You want a simple approach to when you're looking at an EKG, what is going on. This is a simple approach that I have on tachycardias when I look at them, what's going on, right? So first thing, is this fast or slow? I already know it's a tachycardia, right? I'm looking at the QRSs, counting my beats, okay? Then I look at the patient. Is this patient stable or unstable? So is this patient hypotensive, altered, short of breath? This patient is not stable. I need to do immediate intervention. My QRS complex, is it narrow or wide, right? Is this rhythm regular or irregular? All right. Are there P waves present? Okay. Now, if this is regular, fast, narrow tachycardia with P waves, most likely SVT. Let's get vagal maneuvers started. All right. As I'm doing vagal maneuvers for the patient, tell them to, blow on their thumb, blow in this syringe, get passive O2 started, and then your partner or you should be drawing up adenosine at this time, right? Now, wide tachycardia, I want to stress, always assume it's VTAC until proven otherwise. All right. So don't go searching for something that you don't know. Assume it's VTAC unless it's proven otherwise. So in that situation, you want to go ahead and get your IV started. Go ahead, get passive O2 started. Get the pads on the patient in that situation, right? If it's wide, complex, VTAC, put the pads on the patient. Get your amio drawn up, and let's get rolling, because this patient will decompensate quick. Okay. Now the two biggest causes for VTAC are congestive heart failure and coronary artery disease. So, you don't want to miss it. All right. Now, if you're getting ready to cardiovert the patient, make sure the patient is self-sedated. Okay. In that sense, they're altered, they're confused, and there's some sort of sign of cardiovascular compromise. Don't just cardiovert a pretty good looking patient, guys. It hurts. It's not a good look, right? Why did we just shock this patient? So keep that in mind. All right. So the tools that we carry on our ambulances and helicopters, right? So always we can get a 12 lead right away. We need to interpret our 12 lead. Is this irregular heart rhythm? Is there absence of P waves? What's the QRS complex looking like? Is this patient tachycardic? Are there any ST changes? Is this patient going through some sort of ischemia? What do I need to do next? Is this patient hypoxic? All right. What do I need to do for that? Start them on oxygen. Now, some providers are starting to carry this, but if it's available to you, use your ultrasound. Focus ultrasound if available, right? In your ultrasound, you're looking for cardiac contractility. Is the heart beating as strong as it should? Look at the lungs. Are there any B lines suggesting a fluid building up in the lungs? All right. I have an example of what a normal cardiac ultrasound will look like. So on the right side, left side. So this is called a long axis view of your heart. All right. We're looking at your left atrium, left ventricle. This is when I couldn't get it to move on here. So imagine that its heart is beating. What you're looking for are the valves touching the outside walls and coming back in. That's showing you that's a good contractility going on. Or is my atrium dilated? If my atrium and ventricles are superly dilated, that means I'm holding on to some blood. Why is that happening? Then you can look at your four-wall chamber, apical four-wall picture, the picture next to it, and look at all the ventricles and atrium. See, is the atrium contracting? Is there any kind of abnormality in the heart motion is the fluid building up in these ventricles. So this is, I think this will be in the future coming in for pre-hospital care providers. Once you get good at it, does not take long to put a little probe on the heart and see what's going on, right? It gives you a better idea of what I need to do next. Ultrasound will also let you see in an AFib patient, do they have a blood clot, right? Because if they have a blood clot, my treatment plan will change, right? And then put the probe on the lungs. As you put the probe on the lungs, you'll see the ribs right there, and then you see these lung rockets. Those lung rockets are basically called B-lines. That's basically your fluid is shining through it, and that's letting you know that there's fluid buildup in the lungs. We have pulmonary congestion going on. All right. If y'all have any questions, I'll ask them at the end. But if y'all have anything during the process too, please feel free to ask. I know I'm talking a lot. So let's talk about interventions and treatment. So for congestive heart failure, right? First things first, let's target an SpO2 of 94 to 98%, right? Let's start them on passive O2. If you have high flow, just be careful with it, unless the patient is super hypoxemic. You want to sit the patient upright, all right? It's going to improve your preload, and it's going to improve the heart function. So don't have that patient laying, have them leaning, sit them upright. That's going to help the fluid get movement in the heart, okay? Medications. Now, we can give them nitro because the treatment for heart failure is to decrease our sympathetic nervous system and our RAS system. So if we give them nitro, what it's going to do is it's going to decrease our preload and afterload, improving our heart function. But we got to be careful when we give the patient nitro, sublingual nitro or nitro paste. You want to look at their heart blood pressure. If their blood pressure is greater than 110, you can give them 0.4 nitro sublingual every 5 minutes per state protocol, 3 times, however times your state protocol says. All right. Contraindications for nitro patient should not be hypotensive, should not be 90 systolic 90 or lower. And then always ask them, this is the era of new medicines and stuff. Did they use any Viagra or Cialis or any kind of gas station pill or anything for erectile dysfunction, right? They might be embarrassed. Ask them, right? Because you don't want to get this patient nitro on top of them having taken Cialis or Viagra in the last 48 hours. Now the patient's blood pressure tanks out. We're in a different situation now. All right. Another thing, a lot of our ambulances carry our Lasix. So give them 40 of IV Lasix. It's going to help with the diuresis. All right. Now, most importantly, what we need to do is put the patient on CPAP. All right. We put the patient on CPAP. What we're doing is putting intrathoracic pressure. That's going to decrease our preload and eventually decrease our afterload, helping with the pulmonary congestion. All right. So what the biggest thing for this is, the patient needs to be able to initiate their own breath. You do not put an unconscious patient, an altered patient, because it could be in cardiogenic shock, right? It could be altered. Don't put an unconscious patient or altered patient in agonal respirations, a patient that is throwing up or has any kind of facial trauma or pneumothorax, right? Listen to the patient. Please listen to the patient before you put them on BiPAP. Don't just go up there like, oh, this is heart failure, put them on BiPAP. They have a pneumo because a bigger problem, right? Make sure they're able to follow commands, right? In this situation, morphine is your partner, right? It helps with the patient to be relaxed a little bit, and also helps with preload. As long as their blood pressure is okay, you give them some morphine as well. For pulmonary edema, the mnemonic that I was taught was LMNOP, working your way backwards, right? Positioning, take the patient upright. O being oxygen, oxygenate your patient, right? M being morphine. Morphine will help the patient relax a little bit, take away the anxiety maybe, and allow the patient to be able to take the CPAP, okay? And L being Lasix, right? Give them some Lasix. Interventions for AFib, all right? So AFib could have many reasons of why it's going on. So let's address the underlying disease. Is this sepsis? Is this heart failure? Is this a heart attack? Let's address that if we can, right? If we can't, that's all we can do, right? Oxygen. You want to start this patient on passive O2 to maintain oxygenation. Now, for AFib, there's multiple medications we can give. There's rate control and rhythm control, right? AFib, you want to do rate control first with a goal of heart rate less than 110. We have beta blockers, such as labetalol. Some ambulances carry labetalol. Make sure you don't give this patient beta blockers if they're hypotensive, bradycardic, or COPD patients. All right. Then you have calcium channel blockers, such as diltiazem. You can give patient diltiazem as well, but make sure the patient is not bradycardic or hypotensive. All right. Now, class 3 antiarrhythmics, such as amiodarone, are really good for rhythm control, but you got to be careful with rhythm control. You got to make sure the patient's anticoagulated. Now, I forgot to mention this early in the pathophys, but I'm gonna mention it now. Why should the patient be anticoagulated, right? As you're in AFib, as your atria is just fibbing away, right, just going crazy, you get blood stasis. Your blood is just kind of going in circles, not moving forward like it should. As your blood is in blood stasis, you're forming a clot, right? Most of the time, it'll be in your left atrial appendage. So the patient has a blood clot. We get them back in sinus rhythm, and that part of the blood clot could break off, right? And then you could cause the patient to be having a TIA, a stroke, or a acute mesenteric ischemia. So it could go to your gut system. Your gut could start dying, or acute limb ischemia, right? So when you see a patient in AFib, right, ask them how long has this been, right? If it's new onset AFib, less than 48 hours, you can give them some amiodarone, right? Now, if it's not, and they're not anticoagulated, I would just try to do rate control, unless the patient is unstable. If the patient is unstable, meaning hypotensive, short of breath, altered, I'm gonna do electricity. I'm gonna do direct cardioversion, because at that point, I'll deal with the risk of having a clot, other than a patient that's gonna decompensate on me. Okay, so be careful when you do use electricity to make sure that this is AFib. So you cardiovert AFib in the sinus tach. It's a heart failure patient, like we talked about earlier. Ejection fraction is 10%. Patient's going hypotensive. So have all your other interventions ready. Have epi ready. Have levofed ready. Okay. What was that? Also, monitor for the risk of stroke as you do cardiovert this patient. Now, if you get POCUS in like point of care ultrasound in some of these ambulances, you can look at their heart quickly, see if there is a thrombus or not. But if the patient's unstable, shock them. You have to do what you have to do. All right. And then as you transport this patient, monitor for stroke symptoms. One thing with amiodarone or any class C antiarrhythmics, keep a 12 lead on, keep an eye on their QT interval, because it could cause you to go into torsades. Then you know what to do if you get torsades, right? I need to go magnesium. I need to shock them. But always have that thought process there, because if you give this patient amiodarone, you're riding away, not looking at the monitor, and then all of a sudden you just see that nice squiggly lines going on. All right, just be ready for that kind of intervention. Okay. In Alabama, we use the EMSA scale. All right, anybody use the EMSA scale for stroke protocol? Exactly. Right. So we're looking for horizontal gaze. Is it crossing the midline? Are they following commands? Is there any facial weakness, arm weakness, leg weakness? Asking the patient, Nate, what I like to do in the ED is I pull out my phone. Can you tell me what this is? I'll pull out a pen. Can you tell me what this is? Ask them to repeat after yourself. I always ask them to say, it's a beautiful day in Birmingham. It's simple, it's uplifting, hopefully. Get some happy, you know. And if they can say that, most likely not a stroke. And keep it moving. Okay. Any questions about the treatment plan and about CHF and AFib so far? All right. So let's go through some cases. All right. I got just 2 cases, straightforward, and then I'll be done. So you pull up to see, get called to a 56-year-old male, has past medical history of hypertension, diabetes, coronary artery disease, heart failure, has been short of breath for 2 days, says that they've been out of their Lasix for 3 days. All right. Put them on the monitor. You do a good physical exam. You see the patient's heart rate is, they're tachycardic, going at 120. They're hypertensive, 200 or 120. They're tachypnic, and they're hypoxic. And on the physical exam, the patient's talking to you, they're alert, slightly anxious because they're having a difficulty breathing. You hear crackles bilaterally, and you see lower extremity edema. Your EKG shows some sort of ST changes with the tachycardia, and then if you happen to have ultrasound, you see B lines on ultrasound. All right. At this point, what are you thinking is going on with this patient? Anybody? Heart failure. All right. More specifically, right-sided heart failure. Right. Most specifically, what would you want to do for this patient? Huh? O2, Lasix. What else? Sit them upright. If their blood pressure is fine, let's start them on nitro. And then what y'all want to do after that? CPAP, and then what? We gotta start transporting at some point, guys. We can't just let's start transporting. All right. Let's get them in the ambulance and start transporting to the hospital. All right. So this patient was in acute heart failure exacerbation. All right. Everybody said the right thing. We sat the patient upright. We gave him oxygen. We initiated nitroglycerin because the BP did allow us. Patient was talking to us. This was anxious, so we put him on CPAP. If we wanted to, we could have given morphine because the patient was anxious. Kept the 12 lead on this patient to make sure that the patient's not going into acute STEMI or anything like that. And this immediate intervention increases the mortality and morbidity of patients that we will see a lot in our communities. All right. So as a basic, what you could, well, I don't think it's called basic anymore. As an EMT, what you could do is give patient passive O2, put the patient on CPAP, assist them with their home nitro. For medics, right? You can start the IV. You can start giving the patient morphine if you need to. Get the 12 lead going. Put the patient on BiPAP. When they come to our ER, we'll see if the patient is in cardiogenic shock. We'll start them on dobutamine, milrinone. We'll see what we can do for the patient immediately, right? Case study 2, all right? You have a 65-year-old lady come in, said that she's feeling heart racing, sudden palpitations, short of breath, dizzy, and then you put them on the monitor. You see their tachycardic at 160, blood pressure is 110/80, their tachypnic at 32, their SpO2 is 95% on room air. You do a great physical exam. Patient's talking to you, alert, anxious. Their heart is racing, feeling short of breath and lightheaded. And then you get an EKG, and this is the EKG you get. Who would like to interpret this EKG for me? You guys do this all the time, so don't be ashamed. It's okay. Let's interpret this EKG. Huh? Yeah, but let's talk through what we see. So remember the tachycardia approach that I talked about earlier, right? So let's go through that. Patient stable, okay? Stable patient. Is this fast or slow? It's fast. There you go. So everybody did interpret it. Nobody wanted to say that to me. All right. Fast. Are the QRSs narrow or wide? Narrow. So you have fast, stable, narrow. Is this regular? It is. AFib with RVR because it's really fast. All right. So there you go. We went through our approach. AFib with RVR. What would you want to do for this patient? I'm sorry. Find out how long. That's a good one. Find out how long it's been going on. Is this new onset or is this a long-term AFib? Right. What's something else you want to ask this patient? Huh? Are you anticoagulated? There you go. That's another thing you want to ask this patient, right? What else would you want to do for this patient? What medicine she's on, right? What is the underlying cause? Is this the thyroid storm that's going on? Is it hyperthyroidism that's going on? What are we missing? All right. Did they go on a drinking binge? Were they at a party? Did they see Alabama beat LSU? Roll Tide, right? They had a good time, you know. So go with that, right? Ask them, and then what do we want to do after that? Oxygenate them, not medicate them, but when you do get to medicate them, I know beta blockers are category A, but if you're going to give a patient beta blocker or diltiazem, I highly, highly recommend call your online medical control first. All right, because we want to make sure we're giving the patient the right meds for the right reasons, right? It could be an underlying thing that we're missing that we're not thinking about. It never hurts to ask for extra assistance in a situation like that. Okay. So in this patient, we gave him oxygen. We called the medical control. We wanted to get rate control on this patient. Our medical control said, yeah, go ahead, give him some DILT. That's fine. Let's get him to the hospital. And during transport, you always want to continue to monitor signs of stroke because they might have a thrombus that's floating right there, a little bit flicks off. Keep an eye on that. Keep an eye on their limbs. Is this a cold limb? Yeah. Do they have pulses peripherally? Because there could be acute limb ischemia. If their stomach starts hurting a lot, pain out of proportion to exam, are they basically infarcting their stomach? Okay. And then ensure safe transport to the right facility and we'll be good. All right. One big thing I want to leave you with is don't get burned. All right. Don't just look at the reading of the EKG readout. Whenever you do that, tell yourself when you get tried to look at the EKG readout, tell yourself you're better than that. All right. You're better than the computer. Look at it yourself. Because what is this computer calling this rhythm? What is this rhythm? Exactly. So what would we do for this patient? Huh? Unstable. Shock them, right? But we'll get them on pads. We'll get them get the patient going. We'll get amnio drawing, right? Don't just rely on the EKG readout. We go to school, we learn this stuff for a reason. We're better than a computer. All right. I always tell yourself when you get ready to read that, I always tell myself, like, I'm better than that. I'm gonna look at the rhythm strip. You could be tired. You could be on the 23rd hour of your 24-hour shift. Still, you're better than the computer. Okay? Don't get burned. Have a patient in VTAC and you get to the hospital and you done gave the patient nothing. All right? So in summary, for CH and AFib, you want to do prompt recognition and intervene. You want to get a 12-lead EKG. You want to do a good physical assessment to differentiate between these conditions. You want to give patient passive O2, nitro, CPAP, and then for AFib, ask your online medical control, can you give them rate control? If they're unstable, do electricity. And do a stroke rates evaluation throughout the whole transport. All right? Any questions, guys? I'm open for any questions.
Hey, Doc, we had a couple come in online. So the first one is, what about patients, and you may have already answered these, what about patients with longstanding AFib who have new symptoms? How does EMS decide what to treat or not to treat?
All right, so patients with longstanding AFib with new symptoms, if they're unstable, we're going to cardiovert them. All right. If they're not, if they're stable patients and we call our online medical control, their heart rate is super high, we could give them some DILT, or if you carry labetalol, we give some labetalol if their blood pressure allows. All right. Even if they're anticoagulated, if the patient has new symptoms and they're stable, let's get them to the hospital. Then we'll decide what we need to do with our cardiology. If we need to do a direct cardioversion, they could put the probe down their throat, look at the backside of the heart, make sure there's no thrombus form right there, and go from there. All right?
So the next question is, what's the pre-hospital treatment if they are having tachycardia from thyroid storm?
Really just fluids and go fast as you can to the hospital. Honestly, it's nothing that pre-hospital treatment could do. You could treat their pain. You could give them some morphine to kind of help them calm down, maybe, but it's not much pre-hospital. Just get there fast, I guess.
Yeah, the way I usually find if somebody's hyperthyroid is I've treated their dysrhythmia with several things and nothing works. And like 3 hours later, the lab comes back and it says they're hyperthyroid. So if you can pick it up in the field, tell me how you do that. I can't do it in the ER sometimes. So great talk, sir. One of the things that's great when we have the residents, they bring up pathophysiology, new things that, sometimes I even forget about. He mentioned the renin-angiotensin system, and I have like sweats when I hear that, thinking about med school, right? But I bring that up now because we have drugs out there, ACE inhibitors, ARBs, lisinopril. You ever seen a patient on one of those medicines? Right. So everybody in Alabama is on that medication, right? And it's important because that helps restructure, remodel the heart. And so that's why we do that. So if they're on that medicine, they have hypertension and potentially have some early congestive heart failure as well. When you think about that, there are two risks of taking that ACE inhibitor. One is everybody knows you can get some angioedema. You get some tongue swelling. That's a scary thing. An offline kind of way you can treat that in the field is you can do some TXA. There's some good case studies that TXA fixes that. That is not in the protocols. I'm not saying do that. I say talk to your med director about that. The other thing is those medicines really can jack up the kidneys. So somebody on an ACE inhibitor or an ARB for a long time may develop kidney problems, which leads to other issues such as hyperkalemia, things of that nature down the road. So that's why it's important to kind of know the basic pathophys. Another good thing, as he mentioned, the ultrasound. Who here has ultrasounds in the field? Anybody? I know there's some ground units, right? I know that we're putting them into the primary education as well. If you're interested in doing some ultrasound training, starting in January, we're going to put that back out with the EMS Challenge. We have not done it in the past year. The year before we did, but we'll have an ultrasound we'll bring out with us and start showing you some. It's super easy to use. There's no risk. You're not going to hurt somebody. You may get some KY jelly on them, but no harm, no foul, right? Otherwise, there's no risk to that. So we'll do some training with that. And then the other thing I wanted to mention with the great discernment between CHF and pulmonary edema. Lots of folks have CHF, but pulmonary edema is what gets people in the ER and the EMS side. So you got to better treat that pretty quickly. So cool. Great. Thanks. We'll take about a 2-minute break, switch over the slides, and I'll show some inappropriate pictures and some eyeballs. So
thank y'all.
All right, guys, we'll get started. So we're still live online, and we'll get going again for the second part. We had to switch up. Thanks, Dr. Saeed, for doing that. We're going to talk about some ocular emergencies, some eyeballs. So if you had a late night, you might not want to look at the screen in a few minutes because some of these pictures are unique. EMS Challenge, we started this about 10 years ago to bring more physician-led Con Ed to the state, or actually to the region, and now thanks to the Fire College, we do it statewide as well. I won't read what the challenge stands for, but the goal list is to bring practical, pragmatic training out there, things that you can use. And this is all free, so there's no charge to any of this, and it should meet what you need for National Registry. We can also give nursing and physician Con Ed as well. When we go to a venue, the hope is that we bring in the ER staff, the nurses, the docs, to meet and mingle with EMS and kind of improve those relationships as well. We're in Springville in December. We'll get our flyers out, post on the Fire College webpage. And January, we're in Enterprise, and then back at Birmingham Fire and Rescue. February, we're in Trussville and Dothan. We got March. We're full up through June, but if you're interested, just shoot us a text or come by the booth. We'll get you signed up and happy to come out to your location. I also still have several T-shirts if folks are interested in T-shirts. So. Disclosures, we don't make any money off of this. I may tell you some things that sound inappropriate. If I tell you something that seems inappropriate and you don't want to do that, talk to your medical director. This is just educational stuff. I'm not trying to dictate the way you manage your patients. For Con Ed, there's a, obviously, please sign in through the conference for your Con Ed credit. There's also a QR code going around for EMS Challenge. that will get you linked into our emails that you can use as well. So I try to hit a goal for every year, and the goal for this past year is talking about passive O2. So I've said this for the folks that are online numerous times. Places that I'm the medical director for, we're using nasal cannula for our first line source of oxygen delivery. Regardless whether your patient is the little old lady breathing 30 times a minute and needs a couple of liters, or your patient is in full cardiac arrest, unresponsive, you got to ventilate. One of the benefits of the pandemic is we learned that this device actually gives a lot of oxygenation. The benefit to this is also if this is on someone and they decompensate, they get worse, and you got to increase the O2 or start ventilating them, you don't have to pull off the non-rebreather. You just crank this up and put your BVM on top of that. So where I work, if the patient needs oxygen, you got one tank on scene, it goes to nasal cannula. If you got a second tank and the patient is still hypoxic and you got the nasal cannula on 15 liters, you make a choice as a medic. Do they go to a non-rebreather with your second tank, or do you put them on CPAP with your second tank? If the patient is altered and unresponsive, the next thing I'm doing is I'm using a nasal trumpet. I know that's old school, but it works great if they have trismus, all right, or they have a little bit of gag reflex. You can still use a nasal trumpet. You self-lubricate it, right? You take it, you dip it in their mouth for a few minutes, and it goes in their nose. Nasal cannula goes over that. Great way to give somebody oxygen. Remember, the goal of this is to oxygenate and ventilate people. Some people are tough to ventilate. The person that's 4'8", 300 pounds, tough to ventilate. But I can guarantee you I can oxygenate them like this. Right? Ambu bag over that. Now, even if I don't ventilate well, they're always getting oxygen. Versus if I'm not using this nasal cannula and my O2 is attached to my ambu bag, I'm only really giving them O2 when I ventilate. And if that seal breaks, it's not working well. And sometimes outside the hospital, in the back of a rescue going to the hospital, it's tough to keep that seal. So food for thought. For years, I've always kept an OPA in my pocket when I was taking someone's airway, so I can always slide that in and help ventilate if there was a problem. In reality, I don't keep OPAs much anymore. I kind of switched over to blind insertion devices. There are a lot of them on the market. I don't sell any of them. I like the iGel. It's almost redneck proof. It's really hard to mess up. The other benefit to that is these iGels have a passive delivery port on it. That little green tip there, pop that off. You put your tubing from your nebulizer, or you pop your tubing off your ambu bag and hook that on there and put the other end on 15 liters of O2. This person will be oxygenated better than you can do it any other way. All right? That way, if you have to stop ventilating to get the soft stretcher on them, to move them down a stairwell, to move them around the corner, to kick the dog, to put the Lucas on, whatever you're doing, while the ambu bag is off, they're still getting oxygenation. In some states, there are some agencies that slide an iGel, passive O2. Lucas is chewing. They're not even going to ventilate because you get some micro ventilations with the Lucas or the defib arm or the autopulse, whatever you're using. I don't sell any of those things. But oxygenation, American Heart had a big push for years that you can give somebody too much O2. That is BS, okay? If you got somebody that you're giving high flow O2 for and you're doing it for a day and a half, that is too long. If you have your patient for a day and a half, we've got bigger problems than that, right? So that's my push for this year. We'll change to a different push starting in January. So, all right. So eye injuries. Yeah. Normal, abnormal. Abnormal, right? That actually makes me a little bit nauseous, right? So this is a person that was minding their own business, and they caught a beer bottle across the face. And unlike TV, that actually hurts and can do some damage, right? Anybody know what kind of injury this is? And you can't say bad. It is bad, right? Yeah. So when I think about the eyeball, it's a big ball of goo, right? You basically got two chambers. You got an anterior chamber and a posterior chamber. The posterior chamber is where the optic nerve is, the blood vessels, the meaty portion of the eye, and there's that vitreous humor that's kind of a gelatin, kind of chunky material. You can still see through it. The anterior chamber has clear fluid. It's where your lens and the light focuses and everything goes through. But you got your three layers. You got your sclera, your choroidea, then the retina. And then the sclera goes around, turns into the cornea. So two big chambers, anterior, posterior, this big ball of goo. And what's happened here is we've got a laceration across that anterior chamber. And because this is a big inflatable ball, like those squishy toys your kids have, what's happening is the pressure on the inside is pushing this posterior chamber, everything on the inside, out the front. Super bad. So that's an open globe injury. Big risk for vision loss. You do not want to lose your vision. It makes things challenging to do in life, to drive, to work. So we talk about life or limb-threatening injuries. We got those out there. This is an eye-threatening injury, which can actually take away your occupation. So these folks we got to manage. So after we gag a little bit and vomit, what do we do to take care of this patient? Yeah, you want to cover the eye. So historically, we make these eye shields that you put over. My advice is if you're going to use this, don't put padding under it. What you don't want to do is put 2 or 3 4x4s under this pad, under this metal shield to make it nice and soft and actually touch the eye. The goal is don't touch the eyeball. If you touch the eyeball, any pressure on it makes more of the insides come out. That does not go back in. You can't fix that. So the goal is protect the eye. Old school ways to do it in the hospital, a lot of times I'll use a cup, an emesis basin, or a bucket. Works pretty good. Whatever you have that works for you is great. The goal is, don't touch the eye. I also recommend you cover both eyes. If you cover one of my eyes and I know that something's jacked up there, I'm going to be looking around moving, and that's going to increase intraocular pressure and make things worse as well. So emesis basin, bucket, whatever you got, cover the eyes, keep it safe. You want to control the pain because obviously that's going to be painful. That helps decrease intraocular pressure. So some morphine, some fentanyl. Probably want to do ketamine just because of the risk of deep sedation. But if that's what you got, as long as it's the appropriate dose based upon ideal body weight, works great. All right. They start vomiting. That's going to increase that intraocular pressure as well. So those guys are going to need some medicines. Zofran works good. Sometimes 4 doesn't cut it. So sometimes you got to give them a little bit more of that. All right. If Zofran doesn't work, what other drugs can we use to treat nausea? And you can't tell anybody this. Our patients cannot find out this. So, now, Benadryl, yeah, kind of works. Yeah, Benadryl works. Anybody know works better than Benadryl? Oh, I went too far. Benzos. So Versed, Ativan, Valium, those medicines are great antiemetics, and it also chillaxes them and makes them feel a whole lot better, okay? Now, obviously, that's not in protocol. That's got to call somebody. But if I have somebody that's got a foreign body or an open globe, they're puking, I've given them fentanyl, some morphine, gave some Zofran, and they're still pinging, I'm calling to get orders to relax them even more because we've got to decrease that intraocular pressure or we're going to lose vision in that eye. Cool. If that doesn't work for the critical care guys, I would argue that this patient needs an airway. So if this guy's in my ER, he's intoxicated, has an open globe, doesn't have capacity, doesn't know that he's going to lose his eye, can't let him go, I'm not going to restrain him because that's going to increase intraocular pressure, right? So I'm going to do simple things first, try to cover it, pain control, antiemetics. If that doesn't work, I'm going to do some sedation or anti-anxiety medication such as Versed. If that doesn't work, we got to make the decision. We got to take this guy, deep dive him, sedate him to save that eye. Same rationale as if you got a guy who's missing an arm from an industrial accident and he's fighting you. You got to take control of him. Eyes are super important. Cool. You can classify these things in zones, zone 1, 2, and 3. That's all academic. It doesn't matter. They all 3 need to see an ophthalmologist. They need ocular surgery. All right. But zone 1 is over the pupil. Zone 2 is over the anterior aspect. Zone 3 is deep. If you have a zone 3 globe injury, it's usually something that's penetrating from the side, a GSW or something pretty bad. And I'm more concerned about intracranial injuries on that person than intraocular at that point. UAB is lucky. We actually have our own IER. There's not many of those in the nation, so I know it's like cheating. Those guys are really good to EMS. They gave us some lots of good hands-on training. We can actually take EMS patients there. And the mnemonic they use to kind of triage and categorize things is called ACT Jello. So it's assess the patient, categorize, is this a strictly ocular injury or is there other things that need to see an ER physician, and then triage the appropriate location. And you can do the same thing. Anybody here have an ophthalmologist that will show up in your ER at 2 in the morning? Any of the hospital folks? Yeah, right. Same thing. So That's only going to happen for the most part at an academic shop, such as up north in Huntsville, maybe Mobile and UAB, or if you're in a community where you have an ophthalmologist that lives there and is dedicated. But those plans you probably already have worked out. So assess, categorize, triage, and then the jello. So this is for gross external examination for eye integrity. That means look at the eyeball. They talk about doing light palpation for orbital pressure. And then the ocular vital signs or visual acuity, intraocular pressure, looking at pupils. Is it reactive? Can they move that? And then confrontational visual fields. In reality, as an ER doc, I'm only doing these. I'm looking at the eye. Is there an injury? My vital signs are visual acuity. You can break out your handy dandy pocket eye chart, or I pull up my badge and say, hey, can you see my name? It's gross vision is all I'm looking for. All right. I'm not touching the eye. I'm checking for pupils or reactive, and then I'm looking for extraocular movements, right? So basically what I'm doing is, hey, dude, look at my finger, look to your left, look to your right, look up and look down. If they can follow you, that tells you that all the muscles are intact, pretty good control of that. And then I'm doing pupillary exam as well. Gross vision, you don't have to use these eye charts. I don't use these. It's basic, can you see my hand? Yep. What's my name? If they can read my name, their vision is better than mine. I'm good with that. All right, so open globes, those are concerning. Those are surgical emergencies. Those are sight threatening. They need to get to an academic shop as soon as you can. What is this? This is somebody that has a big red spot on their eyelid. They say it's sore. Anybody know? I put the Ferguson pronunciation of it up there, chalazion or chalazion. Some people call these styes as well. They're actually a little bit different. These are usually a cyst in the eyelid itself. Most of the time, they're not painful. So I would say that I diagnose more styes because they're painful than these, because most folks that come to me and complain of this, their eye hurts, and that's why they're there. This is a big cyst that's inflamed. Most of the time, we treat this with warm compress. They go down, and then you see an ophthalmologist to have that surgically removed. I am not going to drain a cyst on somebody's eyelid because the risk of me putting that needle in the globe and causing more harm is way too high. I'm not going to sew up an eyelid because if I sew it up, there'll be stitches on the back of it, and when they blink, it's going to scratch the eye. That has to go to the operating room to get fixed. So usually painless, but I would say in America, everything hurts, so they're going to complain of pain. But you'll see some folks have some of these, and these have to be removed by surgery. A stye is a little bit different. I think of it more like a folliculitis or an abscess along the hairline of the eye. Warm compress, most of these folks need antibiotics. The literature talks about we don't use a lot of antibiotics for that, but in real practice, we use a lot of antibiotics because the risk is it turns into something like this, right? And then it can go into something like this, right? Cellulitis around the eye. And the problem with that is what sits behind the eyeball? The brain, right? Big risk for bad infections. So historically, for the styes and the chalazions, we don't do antibiotics. In reality, I would bet you that 95% of all the docs are going to treat those eye issues with antibiotics to prevent cellulitis. Cool. So when you have a big infection that covers the entire lower lid, upper lid, or both, you got to think about it as what we call orbital or preorbital cellulitis. All right. And the difference is there's a septum that runs around the eye that kind of protects the eye because behind there is the brain, right? So if the infection is outside that septum, around the eye on the outside, usually oral antibiotics, warm compresses, folks get fine in a couple of days. If that infection is behind that septum, they need IV antibiotics, and they needed it probably 2 hours before you saw them, all right? Or the risk of meningitis, vision loss is pretty bad. So how do you tell the difference in the field? The big way is you think about risk factors. Is this patient a diabetic? Are they on chemotherapy medications? Are they advanced age? And the other thing you can do is you have them move their eyes for you. So if someone has orbital deep cellulitis, they cannot move that eye because there's infection and pus all around those muscles. It hurts. So if I'm doing my initial exam where I look, pupils reactive, great. Hey, look left, look right. Oh, you can't look left. What's the problem there? I'm thinking that's a deep-seated infection. That person needs to get to the hospital, needs IV antibiotics. Most of the time, they don't need an eye surgeon. A regular ER general admission can do that. We'll scan them at the hospital and look for an abscess. If there's abscesses, then we have to get a surgeon involved. But most time we can treat this with IV antibiotics. But again, the big risk to this is we don't recognize it, we don't treat appropriately. It can lead to meningitis, which actually kills people, which is poor form. So my eye exam is the same for everybody. Looking at the eye, any obvious signs of injury, redness, what do I see going on there? The next thing, is the pupil reactive? Does it move? And the next thing, can you look left, right, and up and down? Sometimes you can get confused because of histamine response, cat allergies, dog allergies, mosquito bites, things like that can make that. The only way to tell a difference is get that eye open and see if there's any entrapment. And that's really hard to do with that. So a lot of times these folks, we're going to be treating both ways at the same time. They'll be treated for an allergic reaction with steroids, with Benadryl, etc. But I'm already giving them antibiotics because I can't evaluate that eye. At the hospital, we can do a CT scan and that will look for deep infection, but sometimes that takes hours, right? So this person can get antibiotics until I can prove it's not an infection there. Blunt trauma, this is an oldie but a goodie. That's not a common cause of blunt trauma there, but we see a lot of this, right? Airbags, direct force to the eye, and you can get this injury right here. Anybody know what that is? Hyphema, right? So we see more and more of this now because most Americans, and I would say all Alabamians, are on what drug? Blood thinners, right? Yeah. So blood in the anterior chamber. So risk factors for this would be anticoagulation, advanced age, somebody who's already had ocular surgery in the past. And the risk of this, the first risk I would say is if they had enough force to cause bleeding in that anterior chamber, you got to think about intracranial issues. What else is going on? The blood supply to the eye is kind of strange. So it's on the periphery. You don't have blood vessels that run through that vitreous in the middle. Or pretty significant force to cause those things to bleed. So blood in the anterior chamber is a red flag for other significant injuries. The cool thing, though, with hyphemas is most of these folks do well with these. So if you treat them appropriately, you recognize it, they're not anticoagulated, most folks do good. So even somebody who's got a complete 100%, has got about a 50-50 shot of going back to vision of 20/50 or better. So that one there, I'd say is about 30%. So we're talking about a 1 out of 10 chance of not getting your vision back to normal-ish. That one's a little bit more concerning. That one's about a 50-50 shot, right? But I say that, but that's going back to 20/50 vision. So that's still not 20/20, still not great stuff. Now I know for us mature people in the crowd, 20/50 is a great vision, right? Roll Tide, right? For the younger folks, you want your 20/20 back. You kind of see the difference there. So it's still a significant injury, but there's hope for that. So how do we treat it? The first thing is we got to recognize it. So we do assess, we categorize, we triage the patient. We're going to do our jello. I'm going to look at the eye. Oh, look, there's blood in the anterior chamber. Pupils reactive, look left, look right, look up, no other injuries. All right. I'm going to risk stratify them. Are they anticoagulated? What was the mechanism of injury? What is your GCS? So if this is the airbag to the face and I see a hyphema and they're 93 years old on anticoagulation and their GCS is 13, I'm more concerned about a head injury than an eye injury, right? So I risk stratify. And then what you want to do for these folks is we want to give them drops to dilate that pupil. We want to make that pupil stay fixed for a while. And the reason we do that is because you think about the anatomy with the ciliary bodies. Every time the pupil constricts and then dilates, all right, that blood as it dries gets stuck to that and you start tearing that muscle. And then they're going to have an asymmetric pupil. They get vision problems, changes like that. So our goal is to put drops in the eye to dilate them so they cannot constrict anymore, okay? Some people say you can cover that affected eye and make it where it doesn't work, but again, you have accommodation. So there's no way I can dilate both eyes and keep it that way for 6 weeks. Nobody's going to appreciate that. So you dilate that one eye and cover it up pretty good. Sometimes, well, we'll talk about with glaucoma, sometimes you get increased intraocular pressures with this, and the eye docs will have to go in and drain that fluid out, but that's fairly rare. All right, this is an older lady in her 60s, inside a dark room, came out. All of a sudden, now she has a headache, nausea, vomiting, and she's got blurry vision in one eye. Left pupil is great, right pupil is fixed and dilated, and it looks kind of hazy around that cornea. You try to shine your light in it, it's non-reactive. You say, hey, can you look up? Can you look down? Look left, look right? She can. So what's going on with this lady? That's a hint. That's treatment for it. Glaucoma, there you go. The guy in the front row, good job. Yeah. Yeah, glaucoma, right? So actually, we don't treat this type of glaucoma with that CBD. Older folks, glaucoma, you can. It's a different patho, but so basically what's going on here is as that pupil dilates, you get more fluid into anterior chamber and it doesn't go out. So it causes intraocular pressures to go up and they get vision loss. Usually it's headaches, nausea, vomiting. I'd advise anybody that you evaluate with a headache, you look at their eyes. In the ER, if somebody comes in with a migraine and they say, I always get headaches, I got blurry vision, my head hurts, I'm not going to shine a light in their eye right then because it's going to make them mad. What I am going to do, though, is I'm going to give them some pain control. Come back in a few minutes. When their pain is better, I'm going to evaluate the eyes. You don't want to miss this. This is another ER mistake we see. Sort of like the thyroid I talked about. We usually pick this up at time of discharge when they're not getting better or when they come back 6 hours later because we didn't look at the eyes. So super important to look at the pupils for these things. So the nutrients for the anterior chamber of the eye come from the posterior. What it does is it comes from the posterior chamber, it goes around the iris, fills that area up, gives nutrients, and it goes back behind the ligaments there and drains out. And with acute angle glaucoma, you get more fluid in the anterior chamber and it pushes everything back. And because of that, it can't drain. So posterior to anterior. And as that pupil dilates, that angle gets more narrow, right? And less fluid goes out, more fluid comes in, and it makes it worse. The way you diagnose this clinically is you look at the eye, the pupil is fixed, unreactive, and there's no neuro complaints. In the ER, we can get a pressure on it pretty easy. In the field, you can't do that. But I'd argue that if I got someone with a headache, the neuro intact, and one pupil is fixed, it is acute angle glaucoma, which again is an ophtho emergency. You can lose vision in that eye long term after about 4 to 6 hours if you don't manage that. It's another picture of a different one, a cloudy cornea, fixed pupils. Fixed pupils should always make you uncomfortable, right? So treatment for this, what we want to do is we want to constrict the pupil now. You know, on the other one, we want to dilate it so it doesn't move. Now I want to constrict it. And when I constrict it, that angle where the limpus is gets bigger and more fluid goes out. So we give drops in the eye about every 3 to 5 minutes to constrict. I give drops in the eye that make the back part of the eye quit making fluid. Now, it takes hours for that to work, so I'm getting ready for later on down the road. The thing that fixes them right now is constriction. If that doesn't work, you can take a needle, stick it in that anterior chamber, and drain the eye off. And again, I need Zofran if I'm going to think about doing that, because that makes me sick. That's usually an ophtho guy doing that. And then the ophtho guys can also come in and they can use lasers and make a hole and drain that out and fix that almost immediately. So pretty easy procedure to do if you recognize it and you get them to the right place. Cool. So this guy's got one fixed pupil. The right pupil is fixed, big, doesn't react, it's pointing down and out. The left pupil is working. There are a lot of different syndromes out there that talk about having fixed pupils, and I'm not going to talk about any of those, so I'm Xing that out of there. All right? So my thoughts on fixed pupils, Three things I think about. If you have a fixed pupil that's down and out, the other eye works, guy's neuro intact, everything's moving, this is an aneurysm in the brain until proven otherwise. Okay? This guy needs to be to an ER and get some imaging to look for an aneurysm. So what's going on is you got a big vessel that runs across that optic nerve. Is that aneurysm grows and makes it where you can't move your eye and the eye gets fixed. No harm, no foul, until that gets so big it ruptures, and then what happens? They die, right? So fixed pupil, neuro intact, especially if it's down and out, is an aneurysm to proven otherwise. They go to the ER, they get imaging. Yes, you can get things in your eye that affect this. Yes, it could be acute angle glaucoma, but you picked that up on your exam as well. But aneurysm to proven otherwise, right? If you got a fixed neuro intact acute angle glaucoma that's not down and out, you can think acute angle glaucoma is the other thing. Then obviously if they have a fixed pupil and they have neural deficits, it's a stroke. So fixed pupil neuro intact is one of two things. It's an aneurysm. Most of the time that pupil you can't move, so it's down and out. If they can move it, it's acute angle glaucoma. All right. If the pupil is fixed and they can't move their arms or legs, sign something bad, they're having a stroke or a head bleed. Does that make sense? So that's the Ferguson redneck ER way to figure out what's going on with that fixed pupil. Corneal abrasions, you'll see these in the field. In reality, these are not super significant. They cause a lot of pain, discomfort for folks, but long-term prognosis is good. The cornea is basically almost like the skin. It has multiple layers. You can scratch that. It heals up pretty quick. So little things can do that. The way we check for this in the ER is we do our assessment. Pupil's reactive. I see no signs of open globe. They can move everything. At that point, I give a topical numbing medicine in the eye. If their pain goes away, I fix the problem. I know it's a corneal abrasion causing this because if there was a stroke, an open globe, glaucoma, that topical medicine does not work. Some states, EMS carries tetracaine. So a little bit of tetracaine, pain goes away, great. I think that's what it is, corneal abrasion. The next thing I do is we drop some fluorescein in there, turn on a Woods lamp, which is really just the same light they use at bars to make sure you're of age, right? A black light, and I'm looking to see uptake. If I see that, they get antibiotics, and they go home, and they see the eye doctor in 7 to 10 days, okay? Obviously, if they wear contacts, they aren't going to wear contacts anymore. If they're a diabetic, they should get follow-up sooner. And sometimes the diabetics, I get stronger antibiotics too than I do regular folks. But corneal abrasions, pretty common, see a lot of those things. We can actually treat those in aid stations as well. All right, how about that one? Is that a corneal abrasion? No, that's horrible, isn't it? Yeah. So what? Plus some more, yeah. So this is a guy with a crowbar to the face. What's the biggest concern for this guy right here? Brain injury, yeah. Eyeball is second, and I would argue that his eyeball is already out. It's probably not going to be salvageable. So it's going to be closed head injury management, prevent hypoxia, all right? Make sure he is not hypotensive. If he is altered and unresponsive and you take his airway, you're not going to blow off CO2 and hyperventilate him. So normal entitled CO2, prevent hypoxia, make sure his blood pressure's up, looking for things that kill the people or kill the brain. After that, for this one, if he's going to be transported, how are you going to transport that one, that eye? You kind of hose, right? Yeah. So he's going to be saline soap gauze across the eye and maybe a big shield, but that's going to be tough to manage. I would not be as concerned about touching that one because it's probably gone. If there's a way to secure it without touching it, great. But you may have to put some saline gauze, lay across the top, and to put eye shields across both eyes for that guy. Cool. This is another one. What's going on here? This is somebody that was weed eating and a rock flew in their eye. Could it be a corneal abrasion? Could be. So I'm going to look. Is the pupil reactive? Yep, kind of reactive. They can look left and right and look up and down. But that pupil looks kind of funky, right? Abnormal. So this is actually an open globe as well. It just is not as pronounced as that first one. So this one, I'm probably not going to put that tetracaine in there. I'm probably not going to poke it. I'll still do my shine to light. Hey, follow my finger, look for other injuries. And then I'm going to cover both eyes. They need an ophthalmological eval, an eye surgeon. So unequal pupils, history of trauma, that's an open globe until proven otherwise. This is a good one here. Normal or abnormal. Yeah, what's the biggest concern for this guy? Intracranial stuff as well, right? Yeah, don't grab your hammer, don't do that. But you can look, you can see he's got the injury there at the limbus. We got a little bit of blood in the anterior chamber. We know why. Okay. How are you going to secure this? Yeah, so this guy is, for me, it's probably going to be deep dive sedated. He's got to go to the OR. If this is me, you don't have enough medicines to give me to make me calm down without me not breathing, right? So this guy probably needs passive O2, great sedation, airway management, and a general ride to a place that can take that out and potentially save his eye. So at the academic places, these eye surgeons can do a lot of things. We see a lot of folks with impel-formed bodies, and you think they got complete vision loss, and they do pretty well. If this person gets 30% of their vision back in this eye, and that left eye is great, they'll probably do fine in life because both eyes work together. But it could be pretty bad. No. Do what? Yes, the eye can be saved. Yes, it can be saved. Yes. Cool. Here's another one. We see more and more of these folks being anticoagulated. So this is someone with blunt facial trauma on an anticoagulant. You can see there's a huge hyphema. It's almost 100%. That conjunctiva is way out, right? Tense orbits, a lot of blood loss. So you got a retrobulbar hematoma. In short, you got blood behind the eye, pushing the eye out. So it's tugging on that optic nerve artery and vein, and you got to release that pretty quick. So again, usually deep sedation, but what's going to happen is you're going to have to go in and numb up on that lateral canthus, put a pair of scissors there, clamp down, then you reach in and you cut that, releases the eye, you get a lot of blood expelled, and hopefully that eye gets better perfusion. It's almost like a compartment syndrome, but for the eye, okay? If they're on anticoagulation, though, the risk is they continue to bleed. Most people are going to diagnose this with a CAT scan, but this should be clinically relevant that you recognize the fact this is bad. This is an older person, swelling, anticoagulated, not as pronounced as that last one, but this person has entrapment. They can't move, right? So we got same thing, a retrobulbar, blood behind the eye can't move, super concerning. They need a lateral canthotomy as well. So eye stuff, pretty bad. This is the guy that came from the city jail and got jacked. And his exam's tough to figure out. A little bit intoxicated. He says his vision is blurry in that eye, but it's full of blood, so who knows? So the question is, does he have an open globe or not? So the way I evaluate this is I'm going to check for pupillary reflex. I'm going to be very careful about pulling his eyelids up and down, because if he has an open globe, I don't want to push on it, right? I'm going to try to get him to move, all right? And either if he can or cannot move, he goes to CAT scanner, and on that CT, I can look to see if that globe's intact. But eye injuries can be bad for these folks. So you get folks that get painless vision loss sometimes as well, just random. So 46-year-old male, painless vision loss, you can get a central retinal artery occlusion. It's like a stroke, but in the eye. So you can have strokes of the brain. You can have clots that go to the heart that cause STEMIs. You have clots that go to the bowel that cause ischemic bowel disease. Same thing in the eye. So a lot of these times, if it's a central retinal artery, the main artery that goes there, these guys will say, hey, yeah, I got no eye pain, but a couple of hours ago, I just can't see out of my left eye. I'm not sure what's going on. Maybe I got something in my eye. My evaluation is going to be, is the pupil reactive? Are there signs of trauma? Can you move? In the ER, I add on pressures. If the eye pressure is great, I got to start thinking about central retinal artery occlusions. These are strokes, but we don't treat them like strokes. You would think that we'll be using T and K like we use for our strokes or our heart attacks. There's some data that some places are doing that now, but it's still investigational. Because in reality, you got to open that vessel up or that part of the eye dies. It's just like having a STEMI or a stroke. Risk factors, the same thing for heart attack. So hypertension, diabetes, AFib, you can throw these clots. Sometimes you can have a branch artery occlusion where you just get a little bit of vision change. And a lot of folks will get those and not even come to the hospital for it because I got a little bit of vision loss. All right, still kind of blurry, doing okay. 4 or 5 weeks later, a little bit more. And then within a year, their vision is really bad because they have minor strokes, minor ischemic events. You can lose your eyesight for that, yes. Yeah, so there's some anecdotal therapies. Sometimes we do orbital pressure. If we recognize this, tight pressure. But most of the time, most people that have this, it's too late. It's after that 4 to 6 hour mark, like it is for heart attacks and strokes. Hopefully, moving forward, there would be find a dosing of T and K or T and P that can fix this, because you can have random young people as well that have these central retinal artery occlusions and have vision loss, and it just changes your life. So, not a good thing. So, it's a stroke. We don't treat it like a stroke. A lot of times at our shop in downtown, we'll get calls from the opto guys like, "Hey, I got this guy that's got a CRAO. He needs to come down for imaging." And it's like, well, how long has it been going on? Oh, it's been going on for a couple of days now. So out of the window for anything, even if we had something to give, but you work them up like you would a stroke as well. So it's a stroke, but it's not a stroke. Retinal detachments we talk about. Most people who get a retinal detachment are going to say, yeah, I was doing fine, and all of a sudden I sneezed or coughed. Maybe I jumped into the pool, and now I got this cloud that's kind of moving like a wave. They also get these lights. They get stars they see. And what that is that retina pulls off of the back part of the eye. It gives a chemical signal that makes you think you're seeing lights. So it's like, yeah, I got flashes of light. And now I got this curtain I can't really see well. That's a retina detachment, okay? The people that are high risk for that are like for everything else. Your diabetics, the folks who've already had like laser surgery, eye surgery in the past are high risk for that. And you think about traumatic retinal detachments, again, so blunt trauma, little things like cough and sneeze and all that nature. So these folks need to get to an ophthalmologist within the next 4 to 6 hours as well to get that retina reattached, because when the retina pulls off the back part of the eye, it loses its blood supply. If you can tack it back in quickly, they get complete vision restoration. If you can't, vision loss, which again, in our field is not a good thing. So old age, diabetes, trauma, we talked about that. For a vitreous detachment, so this is not the retina, the gel that's in the eye is attached to the retina as well. It's thick, it's got a membrane. As we age, that gel loses some of its mobility and gets thicker, and so that can pop off and tear. The retina stays fine, but they start seeing floaters. So, hey, I got some new floaters in my left eye, I'm not sure what's going on. They don't get that curtain sensation for the most part, and they don't get those flashes of light because that retina is not being fired on because it is still intact. That makes sense? So you get a vitreous detachment. Diabetics will also get increased blood vessel growth in the eyes, and you'll see these type 2 diabetics that will have sudden vision loss because they got cloudy floaters, and it's the eye itself is just leaking blood in that posterior chamber. Most of the time with that will clear, and we can go in and you can laser those vessels, and that gets better. And as long as you get your diabetes under control, things go well. So, questions, comments, or statements within reason about eyeballs? Yes, ma'am. The question is there a drug of choice for a patient to sedate somebody with an eye injury? And it's really the drug that you have. Yeah, I will not use ketamine. So if I'm trying to sedate someone because they're anxious because they got a open globe, I'm going to do pain management first with some antiemetics. Then I'm going to try benzos at probably 0.1 mg per kilo, as long as they tolerate that. If that doesn't work and I have to take their airway, then I'm probably use something like propofol or Morversed or something like that. Correct, right. So ketamine old school theory was ketamine increased intraocular pressure. It probably does not, to be honest with you. Drugs that we use, the flight guys, like etomidate, I would not use etomidate. Etomidate causes myoclonus sometimes, increase the intraocular pressure. If I'm going to use a paralytic, I'm not going to use succinylcholine because fasciculations. I would use rocuronium as well. Yeah. Yes, sir. Yeah, there is, because two issues. One, the question was, is there a danger to irrigating the eye looking for an open globe? And I'd say, yeah, because if you're going to irrigate that eye, you're going to increase intraocular pressure. The other problem is I'm squirting stuff in the eye, and there's probably trash around there. I may be throwing foreign bodies in there, making it worse. So my advice, if you think there's an open globe, screw it. Treat it like it's an open globe, protect the eye, pain control, sedate a little bit, and get to a place that can fix that. Yeah, just risk to benefit ain't worth it, my opinion. Yes, sir. Yes, sir. So the question is about with eye abrasions, after you irrigate and kind of wash them up, can they heal over time? Yeah. So the cornea, it regenerates real quick. So those abrasions will heal in days sometimes. So as long as it's not a deep injury like an open globe, they do pretty well with that. So again, some states allow EMS to carry tetracaine. It's a great diagnostic tool. If there's no open globe, a few drops in that, if the pain goes away, you know it's something superficial. It works wonderful. Other questions, comments, or statements within reason? Yes, sir. Oh, that's horrible. Yeah. So the question was, how about a chemical burn with an open globe? I would say that's a horrible day. So I think that's going to be depending on which doctor you ask what to do. If you have a chemical burn and an open globe, you probably got chemical burns to the face as well. So you probably have to decon, and at that point, you're just taking the risk of making the open globe worse. That's a nightmare situation. Yeah. Other questions, Chief?
Hey, Doc, could you talk a little bit about the operational decision-making, mostly for the Birmingham area, on whether to take a patient directly to the Eye Foundation or to go through an ER?
Yeah, so in the city of Birmingham, if you're EMS and you want to go to the Eye Foundation, Callahan Eye Hospital, if your patient is normally healthy, and by healthy, I mean they can have diabetes or hypertension, but I don't mean the 64-year-old missing 2 legs on 48 medicines, right? Normally healthy and has an isolated eye complaint that's not traumatic, Eye Foundation is a great place to go. I would argue that if they're wee-eating and they have a foreign body sensation, you think open globe, they go to the ER, the main ER, academic place, because we got to get images. And getting images at the Eye Foundation is challenging. So if you think glaucoma, because it's a fixed pupil, not reactive, they got a headache, and everything else is neural intact, sure, Eye Foundation is fine. If you think it's a corneal abrasion, that's fine. A minor chemical injury, that's fine. Trauma probably needs to go to the main place so we can get images. Yeah. The Eye Foundation is great because it has a lot more diagnostic tools there that they can look at the eye and do different things, look for optic neuritis, that look at the chambers through a slit lamp, things that we can't do in the ER without calling them over. So the other thing for places that don't have the luxury of being near the academic places is the EMS administrator. My advice would be talk to your ER, see what kind of opto coverage you have. It's probably limited, but then reach out to your community. A lot of places have optometrists, different type of training, but they can do a lot of the things that we need except for the surgery. So maybe you can have some kind of an arrangement where they can come see the patient in the ER, or maybe you can have an alternate destination to their clinic by new rules, right? But I would have some kind of plan for both minor and major eye emergencies in your community, because just like trauma, just like stroke, just like STEMI, there is a time factor involved in that. And figuring out how to do that at 2 in the morning on a Saturday is challenging. It's better to be done sometime during the week. That makes sense? Cool.
Hey, Doc, we got a little bit of discussion about curiosity, I guess, about the relationship between diabetes and eye problems, specifically blindness, and relationship between hypertension and blindness.
Yeah. So for diabetes, the problem is because you're diabetic and you have limited blood supply to the eye thinks that it needs more blood vessels to give itself nutrients, right? And so it makes new blood vessels in the eye. And you don't need those there because you have to see through that goop, right? So you get more blood vessels that are made, and the ones that are newer have thin veins, thin walls, and so they rupture and bleed. So you get blood in that anterior and posterior chamber, and that's the problem. The other problem is because of fluid shifts, because your glucose goes from 400 for the past 12 years to now 90 because you're now on your medicines. You get shifts in the fluid, and those vessels get tension, and they rupture, and you bleed in there. So that's the big issue there. For hypertension, it's the fact that you're so hypertensive that it strains those vessel walls, and you get bleeding and increased vasculature, which causes more bleeding, and more of the eye cannot be used to see because there are more vessels there. And that's the redneck Ferguson interpretation of eye disease.
Is there a big relationship between antihypertensives, particularly beta blockers, and eye pressure?
I'm sorry.
Got some people asking about different blood pressure medicine choices, like for chronic hypertension control.
Yeah, so I would, the mainstay there is that, so hypertension is a chronic problem. So if you're hypertensive for a couple of months, couple of years, probably not a big deal. I'm not saying go out and don't take your medicines, right? The problem is 5, 10, 15 years of that causes long-term problems you can't reverse, okay? Same thing with diabetes. You can have diabetes as a young person, type 1, and have a couple of years where you're growing and growth, where you have A1Cs that are high and have issues. Get through that, and you manage your diabetes for the next 30 years, you can live a normal life. It's the chronic long-term strain on the body that gets you with that. So for hypertension, whatever medicine you take, be good at it, take it appropriately, and make sure it works. Same thing with your diabetes. So other questions or comments within reason? Sweet. So this is a slide I show all the time, and it's a little bit of sarcasm on my part. The first part is, you see there's a doctor and an EMT, and you recognize the difference in those two, right? The doctor has bigger arms, right? Makes me feel better about myself, right? But the slide over here to your right, the picture is, I imagine that this day laborer here is the medic in EMS. And this guy is not just a day laborer. He's a dude being held over the rebar, taking care of things. And the folks above are the healthcare system. So we, as a healthcare system, the hospital, the physicians, the nurses, we should support EMS better. We got to bring EMS into the mainstream healthcare to get the right funding, the right training, the things that you'll need, because you're doing the same job we are, right? Same skills, same everything, but in a more challenging environment, okay? So we as a system got to do better. The 3 rules that I try to live by for the most part is I don't want to kill people that get you in trouble, right? I want to do what I can to help people. I can recognize an open globe, but I can't fix it. If I sew up your eye, you'll be blind as a pirate the rest of your life. But I can recognize it and get you to the right place, okay? And I want to go in with a clear conscience. That means that if I recognize an injury, I can get you to the right place, make sure you're taken care of. And the way I live by those 3 rules is I always train. I'm always thinking about new ways to think about patients. I'm always making sure I'm up to the job. There's a joke out there that you don't train to get it right, you train till you can't get it wrong. And that's kind of corny, but it's the truth in EMS. The decisions that you make, people live or die because of those decisions, right? And some folks die anyway, but you don't want to be the person making the bad decisions. And the way you fix that is you train, you prepare, and you do it every day. So we're in Springville in December. Our schedule will be posted on the Fire College website pretty soon for the rest of the year. If you need something, let us know. If I said something inappropriate or you don't like, no harm, no foul. Talk to your medical director. This is just friendly advice, suggestions. But if you need something, let us know. I got more challenge coins, and I have T-shirts in my booth too. So last chance. Questions, comments, statements?
Thank you, Dr. Ferguson. If you're in person or online, please remember to fill out one of our attendance forms. You can get it in person by scanning the code on the flyers, online in the Q&A section. There's a link to the form. The password for today's form is Ocular, O-C-U-L-A-R. I didn't pick it. It's too hard to spell, but that's what the password is, Ocular. And that'll be the first question. Please submit your form. You'll get an automated reply with your certificate. If for whatever reason you can't do that, you can always send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the form. Please fill out the form to get your certificate. And I hope to see everybody in December at Springville. Thank you very much for participating.